Yes, Dr. Golani.
Good morning to all. I extend a warm and heartfelt welcome to each and every one of you for today's enlightening webinar. I am Dr. Pradeep Bolani, the co-convener of this event, and it fills me with immense pleasure to witness such a diverse and engaged audience gathered virtually. Your presence here not only adds to the vibrancy of our discussions, but also underscores our collective commitment to advancing knowledge in our field. I am genuinely anxious about the prospects of delving into the insightful and collaborative conversations as we embark on this intellectual journey together. By consistently providing captivating webinars, SPSR has established itself as a premier platform for knowledge exchange and professional development in the pharmaceutical sciences. I am confident that today's session will uphold this reputation, with attendees benefiting greatly from the expertise shared by our esteemed speakers. Let us seize this opportunity to learn, engage, and contribute to the advancement of our field. Welcome once again, and I look forward to a rewarding webinar experience for all. Thank you for joining us today. Today is a significant milestone as we gather for the 47th SPSR International Webinar on targeting immune evasion in pancreatic cancer. This event is a part of a distinguished series hosted by the Society of Pharmaceutical Sciences and Research under the esteemed mentorship of Dr. Shashi Alok, National President of SPSR. Under his guidance, the SPSR continues to play a pivotal role in advancing knowledge and innovation in the field of pharmaceutical sciences. The SPSR is dedicated to advancing the pharmacy profession through a multifaceted approach. Our objectives encompass the organization of conferences to campaign the causes of pharmacy, contributing to programs and services that address the health needs of India and focus on disease prevention. Additionally, we actively recognize and honor distinguished pharmacists who contribute significantly to the encouragement of pharmacy profession. The core of our mission is the promotion and facilitation of the acquisition, dissemination, and exchange of pharmacy knowledge, ensuring a robust flow of information about the practice of pharmacy and pharmaceutical services. Through these objectives, we aim to elevate the standards and impact the pharmacy profession, fostering a dynamic and collaborative environment. We are truly honored to welcome esteemed speaker Dr. Chun-Wai Mai, Associate Professor and Head of Department Pharmaceutical Chemistry, Faculty of Pharmaceutical Sciences, UCSI University, Kuala Lumpur, Malaysia. Dr. Chun-Wai Mai brings invaluable expertise to our event, and we eagerly anticipate gaining insights from his wealth of knowledge in the field. His presence enriches our discussion and adds significant value to our exploration of the latest advancements in the pharmaceutical sciences. We are grateful for his participation and look forward to a truly enlightening session. In our esteemed gathering, we are honored to have the distinguished presence of Mrs. Monika Sabharwal, the convener of this webinar, National Secretary, Society of Pharmaceutical Sciences and Research, and Managing Editor of IJPSR and IJP. Her multifaceted contributions and leadership in these capacities underscores her commitment to the advancing the field of pharmaceutical sciences and research. We are privileged to have Mrs. Monika Sabharwal with us today, guiding our webinar and with her expertise and dedication. Without further delay, I have the distinguished pleasure to invite Mrs. Monika Sabharwal to extend a warm welcome to our esteemed guest speaker, Dr. Chun-Wai Mai. Over to you, ma'am.
Thank you so much, Dr. Pradeep Golani. Good morning, everyone. Ladies and gentlemen, esteemed guests and distinguished members of pharmaceutical community, it is with a great pleasure and honor I, Monika Sabharwal, stand before you as a convener of 47th SPSR International Webinar on targeting immune evasion in pancreatic cancer. Today marks another significant milestone in our growing commitment to advancing knowledge and excellence in the pharmaceutical sciences. Organized by esteemed Society of Pharmaceutical Sciences and Research SPSR. This webinar serves as a backend of collaboration and learning in our field. I'm pleased to announce that we have the privilege to have Dr. Mai with us. He is an associate professor and the head of Department of Pharmaceutical Chemistry at Faculty of Pharmaceutical Sciences, UCSI University, Kuala Lumpur, Malaysia, as our distinguished speaker for this event. Dr. Mai's expertise and insights promise to shed light on the complexities of immune evasions in mechanism employed by pancreatic cancer cells and explore innovative approaches to overcome these barriers. Through his expertise, we aim to uncover novel therapeutic strategies that hold potential to revolutionize treatment outcome for the pancreatic cancer patients. I am delighted to share that we have received overwhelming response with over 3,500 registrations from 17 countries. This widespread participation is a testament of global significance for our topic and its impact on work done in the pharmaceutical field. SPSR has a proud history of organizing successful webinars, providing a platform for international speakers and engaging audiences worldwide. The positive feedback and the continuous support we receive from our audience only serve to strengthen and resolve to continue uplifting the pharmacy profession and fostering excellence in the pharmaceutical research and education. It is an immense honor for us to extend a heartfelt welcome to Dr. Shashi Alok, the esteemed National President of SPSR. His visionary guidance is instrumental in coordinating a remarkable transformation within the SPSR, positioning it as a backend of excellence in the field of pharmaceutical sciences. I would also like to express my sincere appreciation for invaluable contribution of Dr. Pradeep Golani, the co-convener of this webinar, and the organizing committee members, Dr. Sanjay Nagde, Dr. Payal Mittal, Dr. Saurabh Kose, Mr. Ankur Agarwal, and Mr. Junaid Tantre. Their tireless efforts have played a crucial role in transforming the vision of this event into a reality. Behind the scenes, an exceptional team is a backbone for the seamless organization. Their tireless effort and dedication to the excellence have made this a driving force for this successful of this event. I extend my sincere gratitude to each and every SPSR team member for their attention to the detail and the passionate. As we embark on the enlightening journey together, let us seize this opportunity to learn, collaborate, and innovate together. May today's discussion enrich our understanding and inspire us to drive positive change in the fight against the pancreatic cancer and beyond that. I extend my heartfelt gratitude to Dr. May for his invaluable contribution to this event and to you all for your support and the participation always. Together, let us contribute to strive for the excellence and innovation in the pharmaceutical sciences. I extend my deepest gratitude to each one of you for your enthusiastic participation and your valuable contribution. Your engagement fuels a collective pursuit of excellence in the field of pharmaceutical sciences. I am confident that today's discussion will be both enlightening and inspiring, leaving a mark on our professional journey. Once again, I extend my sincere gratitude to each one of you for the integral part of 47 SPSR International Webinar on innovative and crucial topic targeting immune evasion in the pancreatic cancer. Your active participation and engagement is invaluable contribution to our collective pursuit of knowledge and progress in the pharmaceutical sciences. Our esteemed speaker, Dr. May, stands ready to share his invaluable insight and expertise with us. Together, let us embark on this enlightening journey and eager to uncover the new perspectives and potential solutions in the fight against the pancreatic cancer. Stay forefront of innovation with the SPSR. By subscribing to our YouTube channel, you can unlock exclusive access to the upcoming webinars, experts' insights, and groundbreaking research. Join our vibrant community of knowledge seekers and actively engage in the thought-provoking discussions. that shape the future of pharmaceutical sciences overall. Don't miss out the latest updates. Remember to SPSR YouTube channel and hit the notification bell icon for the instant alerts. Join us to discuss this discovery of innovation together. Without further delay, I invite you to join me, welcoming you, Dr. May, as we commence to this 47th SPSR International Webinar. Together, let us explore and strive towards the advancements that hold to promise a bright future for overall patients worldwide. Thank you, and let us begin with the 47 SPS International Webinar. Over to you, Dr. Pradeep Golani.
Thank you, Mrs. Monika Sabharwal, for allowing me to conduct this webinar. And now let's begin with a brief introduction to guest profile. Associate Professor Dr. Mai earned his postdoctoral certificate at Shanghai Jiao Tong University School of Medicine, and he's currently servicing as a head of pharmaceutical chemistry at the Faculty of Pharmaceutical Sciences, UCSI University. He has successfully secured research grants exceeding $1 million and consultancy projects surpassing 2 lakhs US. With a prolific academic career, Dr. Mai has authored over 90 research publications, showcasing an impressive H index of 26. His contributions have accumulated more than 200 cumulative impact factors and garnered over 2,000 citations. Recognized as a chartered scientist by the Royal Society of Chemistry UK, he holds the position of focus group pharmacology chair within the New Medicine Special Interest Group at the International Pharmaceutical Federation. He also serves as the assistant honorary treasurer and chair for the education chapter of the Malaysian Pharmacists Society, Malaysia. Furthermore, Dr. Mai is a valued member of the UCSI University Institutional Ethics Committee. In acknowledgement of his outstanding contributions, Dr. Mai has received prestigious awards on both national and international platforms. These include the FIP Early Career in Pharmaceutical Sciences Award by FIP Foundation for Education and Research, Netherlands, the Shanghai 2020 Foreign Expert Program for Foreign Youth Talent, China, Rising Star Award by Malaysia Association for Cancer Research, and the Asian Young Pharmacist Group Professional Excellence Award. Dr. Mai has been recognized globally through accolades such as the Southeast Asia European Union NAT2 Fellowship by the British Council and the Sultan Mizan Antarctic Research Foundation Research Fellow in Malaysia. His extensive international collaborations have taken him to prestigious institutions such as the Strathclyde Institute of Pharmacy and Biomedical Research, University of Strathclyde, Scotland, UK, the British Antarctic Survey, Cambridge, UK, and the Institute of Protein Biochemistry, National Research Council, Naples, Italy. Dr. Mai's research team is at the forefront of innovation, focusing on designing genomics and proteomics tools to evaluate intervention and to target acute and chronic disorders. They are also engaged in groundbreaking drug discovery endeavors, exploring both natural and synthetic compounds. His commitment to advancing scientific knowledge and fostering international collaboration solidifies Dr. Mai's position as a distinguished figure in the field of pharmaceutical sciences. It brings me immense joy and pride to share that we have garnered the participation of over 3,500 registered attendees from across the globe, representing a diverse array of countries. Among them, we have a significant presence from India, Algeria, Bulgaria, Cameroon, Ghana, Indonesia, Iraq, Kuwait, Malaysia, Mauritius, Mexico, Nepal, Nigeria, Pakistan, Philippines, Saudi Arabia, UAE, and USA. The overwhelming response from such a wide-reaching and varied audience is truly humbling. We extend our heartfelt gratitude to each and every participant for choosing to be a part of this significant event. Thank you all for joining us today. Let's make this webinar an insightful and enriching experience for everyone involved. We have our esteemed keynote speaker, Dr. Chun-Wai Mai, with us today. Welcome, sir. Kindly, I request you to share your PowerPoint presentation and talk.
Thank you very much, Dr. Pradeep. Thank you for the kind introductions. Just give me a very quick moment for me to share my presentation. Okay. Can you all see the slide now?
Right, sir. It's visible, sir.
Yep. Thank you very much. Okay. Thank you very much for the Society of Pharmaceutical Sciences and Research, SPSR, for the very kind introductions and also invitations. And I'm very honored to be invited to share a little bit from our group on the topics that we've been working on for the past few years. And now we achieved some milestones in this particular topic. That's why I think it's a good time for us to also share some of our findings with the rest of the people in this call. So the organizers also have alerted me that they actually had to stop the registrations yesterday because there was overwhelming response. More than like 3,500 participants have signed up, and from more than 17 countries. Thank you very much for all your support, and I hope that today discussions, all the presentation and sharing will be very useful to every one of you. And whether you're calling in from any time zone, so it's a good morning, good afternoon, and good evening to everyone. So today my sharing will be focusing on this targeting immune evasions. So it's on the topics that's very close to our group, because we have a little bit of the achievements, and I will be sharing with you very shortly. So before I begin the presentations, that I really need to acknowledge a few of the important grant funders that actually supported this particular study. Otherwise, we won't be able to sit here to enjoy today's data. So the first is from the Ministry of Higher Education of Malaysia. They funded this particular study. It was one of the grants that I received two years ago, focusing on fundamental research, and that's why most of the findings today are primarily coming from this particular grant. And I also received some of these postgraduate research grants from various institutes. So previously, I was with another higher education institute, and that institute has funded part of the study, and also currently at UCSI University, I also received part of the grant to support this particular study. And definitely not forgetting that all my research collaborators who contributed to the study, and they play a very important role, because it is not something my group can achieve alone. So we definitely have a lot of help from the people who are experts in bioinformatics, and people who are experts in synthesizing compound, and these are the people who have supported this project. And there was also another particular special acknowledgements that I need to make. You realize that some of these pictures that I'm going to use as a background presentation, it was from particular consultations that I do for a particular company. This was a text-to-image AI tools that I use to generate my presentation. So all the background clips arts that you're going to see in this particular presentation, including just now the first landing page, was AI generated image based on the text to image. But rest assured that the data are not generated by AI. It's just the background cosmetics kind of presentation PowerPoint slide was using AI. So let's just begin. I'm sure many of you know about this, but it will be good for us to recap some of the important issues that we face in cancer research before we dive into why our group is very focused on immune evasion, and particularly on pancreatic cancer. So many of you would also agree that cancer is an uncontrolled cell growth event. So in other words, means that the cells are growing without a restriction, and that's why they grow very fast. And most of the time, it is out of control, which means that we do not know how they can actually able to grow at such a fast rate and overcome some of the restrictions that we put in place in the normal cell growth. And because of their extraordinary ability to grow, and some cells grow very fast, some cells grow very slow, some of them grow extra protein, some of them grow extra gene mutation. At the end of the day, if you take out the whole tumor, you will realize that there is a heterogeneity that we are talking about. This cellular heterogeneity, which means that the cells are actually not the same compared to their neighbor. And if I take the whole tumor, if I dissect them and I separate them individually, you will realize that each and every one of the cells are not also the same. And because of this cellular heterogeneity, we also encounter that each and every one of them will respond to treatment slightly differently. Some of them will be very resistant to treatment. Some of them will be sensitive to the conventional cancer treatment, like the chemotherapy, hormonal therapy, or immune therapy. So some of the cells will die in the process when you started the treatment, but some of the very resistant cells will survive. And these very resistant cells, they may actually contribute to more resistant clones of the cancer cells. And eventually, that's the reasons why we have some treatment failure in the later stage of the patient. So we noticed that this is a rather alarming scenario where, because of the cellular heterogeneity, it contributes to a treatment failure scenarios that we always observe in cancer. Another reasons we believe that because of the cellular heterogeneity, each and every cancer cells will have the ability to evade from the immune system. So every one of us will also understand or agree that immune systems will be like our check and balance mechanism. So the immune systems are supposed to come in to eradicate those things that is not right in our body. So cancer cells that grow super fast are able to override the normal growth environment are probably gain some kind of ability to run away from the immune system. That's why the term called immune evasion is always associated with cancer, is because they seem to be able to run away from our immune system. That's why our immune systems are not able to detect them and not able to eradicate them at the early stage. So eventually the cancers can survive in our body and can grow very well or grow very fast. It is because of the immune evasion mechanisms that happen in cancer. So as a conclusion, we know that cancer have very fast growing rate. At the same time, cancer able to evade from our immune system, and they can also run away from most of the conventional treatment. So the problem that we now face is the cells are growing fast and the tumors are growing, and we cannot eradicate them because they are treatment resistant. They are also resistant to our innate immunity system. So particularly pancreatic cancer is a very, very bad prognosis. I think those of you who are working in these cancers, this line, you will know that is one of the most nasty cancer. I particularly pick up this statistics from UK is because we all know that in the UK, in the US, the health facilities is better. The research development is so much better. Patients are also much educated compared to a lot of parts of the world. And because of that, you will expect that the prognosis of cancers will be the better compared to the rest of many parts of the world, including in Malaysia. But you can see in this particular slide, the pancreatic cancer, even in the UK, is a very poor prognosis, whereby there is only less than 1% of the patients that actually survive at the end of the stage. And you realize that most of the patients are actually not doing very well. Like, let's say if you take a snapshot scenario of 9,900 cases was newly diagnosed in 2015, and in 2016, 9,200 of them are actually no longer around. And almost like 95% of the patients will die within a year. And what is more alarming is these patients are usually around the age of like 15 to 50 years old, which is quite young compared to most of the disease. And you also realize that there is another alarming issues is for the past 40 years, despite whatever developments of whatever research and things that we've been doing, there is not much improvements in terms of the survival for pancreatic cancer for the past 40 years. So which is very alarming, which means that we are now facing the case that if any of our friends or families or anyone's diagnosed with pancreatic cancer, it is kind of like a death sentence to many of us. And to the scientists, is something that we still have not able to crack the answer. And this is another snapshot scenario. If you want to compare the prognosis from pancreatic cancer compared to breast cancers or cervical cancers, breast cancers is one of the more common cancers. So if you and me write a grant, most of the time it's very easy for us to justify why do you want to fund breast cancer, because it's one of the most common cancers. But if you look at the statistics, the prognosis is also very good for breast cancer, because it all thanks to the early detections and much understanding that we already gained for breast cancer. So patients tend to survive better and compared to pancreatic cancer. So pancreatic cancers, if you note that this, 93% of them are actually not able to survive. And that's why we have a rather bad prognosis of pancreatic cancer compared to breast cancer and cervical cancer. So if we look at the 5-year survival rate, 5-year survival rates for pancreatic cancers is actually as low as like 2% for among the elderly. And it could be a little bit better for people between 15 to 40 years old. You can achieve up to about 20%. But most of the times we are fluctuating around 9 to 2% of the patients can only survive. So it is poor prognosis. And if we look at this particular snapshot scenario, we actually try to understand what was the reasons pancreatic cancer was very bad in terms of prognosis. And this is a paper that we published from our group. We basically dissect all the available literatures, and we conclude that the immune cells are actually playing a major role in creating an environment that our pancreatic cancer will be able to evade from the cell. So you see there are many of Treg cells, tumor-associated macrophage, and also cytotoxic T cells, and also our CAFs are playing a very important role in creating an environment that lets the cancer cells to be evaded from the rest of the treatment. So this is what we understand so far from the literature. So when we go a little bit deeper, this was a very nice diagram done by my master students. So she have actually looked a little bit deeper, because we understand that immune cells and cancer cells have a cycle. So what you see in the middle is actually a cycles of the immune cells and cancer cells interaction. So let's say at the beginning, our cancers will actually present the antigen. And then once the antigens have been presented, they will start to prime our immune cells. In the step 3, the immune cells will be primed and to be activated. Then our T cells will usually start to traffic in and infiltrate into the tumor cells. And once the cancer cells can recognize the T cells, and the T cells may be able to eliminate them, the last step 7 will be cancer cell being killed by the immune cells, and the immune cells will get rid of the cancer. So this is a cycle that we call the immune and cancer cell cycle. So what my students have done is they should go into a little bit deeper to understand what could potentially went wrong in each and every step. And because we know that immune evasion is a scenario where the immune cells were no longer able to recognize the cancer cell. So would it be possible that it is started as early as when cancer cells antigen presentation is already an issue? So when we dig a little bit deeper, we noticed that there was a lot of inhibitory mechanism in place that drive that cancer cells antigen release. For example, the tolerogenicity cell death that will actually inhibit the cancer cells from releasing their antigen. Some of the mechanisms was also noticed in terms of how they can block the cancer antigen presentation. Because if we block the cancer antigen presentation, which means that there will be no antigen being presented, obviously T cells will not be able to eliminate cancer. So that could be one of the reasons. And we also noticed that in terms of priming and activation, there are some molecules that can help to activate the priming, but there are also molecules or epigenetic abbreviation that actually cause the priming issues and the activation issue. Obviously, as you can see in the step number 4, is the T cell trafficking. So the LKB1 loss and FAK activities can also inhibit the T cells trafficking. Subsequently, in T cell infiltration, where the T cells are not able to penetrate into our tumor cells, so then this T cell infiltration step may be also affected. And obviously, the cancer cells recognition part will play a very important role. And that's why most of our immunotherapies are trying to do is we were trying to make sure that the cancer cells are being recognized by the T cells, and eventually our T cells can eradicate this step. But noticingly, you also notice that there are quite a lot of cancer cells killings that may be able to be blocked by many things. For example, the conventional TP53 mutation, PTEN loss, constituent activations of MYC, and also PD1, PD-L1s inhibitions, CD47s, when epigenetic alteration, and even hypoxia can actually inhibit cancer cells from being killed. So if you understand these particular cycles very well, you notice that the step, each and every step, the interactions between the cancers and the T cells can also potentially go wrong. And that's why most of the cancer cells are able to gain their ability to evade from the immune cells. So these particular scenarios that we capture here is designed particularly based on the literature available for pancreatic cancer. So if you are interested to find out about the other cancers, let's say breast cancers or colon cancers, you may also do a similar literature searching, and you may be able to also complete a very wonderful diagram as such. But if you want to know more about pancreatic cancer, you just have to check the DOI below, because it's a published papers that we already published in the literatures. So you can just pick up this particular paper and you can actually find out more information if you want to know more about that. So moving forward, we understand these are the possible things may go wrong, and these are the possible reasons why immune cells can be not able or compromised by the cancer cells. But we still need to address the issue is, if we know all this, what can we do about it? Can we design a new cancer therapy, or can we design something more targeted to actually uncover, resolve all the changes or issues that we potentially see in here? So when we dig through the literatures, we realized that there wasn't a very clear understanding, or nobody have actually looked through it very, very detailed. And the biggest problems that we face at that junctions of time is pancreatic cancer is not a common cancer like breast cancer and colon cancer. And the number of cases that presented to our tertiary hospital in Malaysia is very limited. And most of the patients only pass away, then only they realize that the patient's already pancreatic cancer. So the number of patients that we can access to do pancreatic cancer study is very limited, and due to the late diagnosis. And those who presented, and probably if the samples was not kept very well, we will not be able to do a very thorough pancreatic cancer study also. And we were trying to also collaborate with a lot of other international parties. And seems like everyone will also have a similar problem. So for us to understand the genomics landscape on pancreatic cancer, we actually leveraging on the available literatures and also the bioinformatics data and the transcriptomic data that is available in TCGA, and also another cohort study from Australia. Because these two data sets is made publicly available, so that's why we dig inside this particular two data set and we take out all the pancreatic cancer patients' genomic profile and we do a little bit of bioinformatics analysis. What we able to identify from this analysis is there was one very important or interesting observation that we found. Patients with containing high cytotoxic T cell activity, the one in the blue line, seems to have a better overall survival and better progression-free survival. In this PACA-AU is an Australian data set. So among them, there has 69 patients that have the overall survivals and the prognosis-free survival data. And when we look into TCGA pancreatic cancer dataset contain 119 data with overall survivals and 89 data with progressing-free survival. We also notice the same trend. Patients with high cytotoxic T cell activity, they have better overall survival and better prognosis survival compared to those with low cytotoxic T cell activity. So that gives us one very clear understanding where I can separate my patient according to whether they have high cytotoxic T cell activity or low cytotoxic T cell activity to predict their overall survival. And seems like cytotoxic T cell activity is an important key factor for us to understand in terms of immune evasion. So subsequently, what we did was, if you still remember the cycles tables that I showed you, step 1, 2, 3, 4, 5, 6, 7, we did the same analysis based on the gene signatures of each and every step of the cycle. So when we do this and we compare and put it inside the database, we notice that only the step 7, which is the step where the cytotoxic T cells are supposed to kill the cancer cells, is significantly different when we notice that the high cytotoxic T cell patients will also have a very good step 7, which means patients with high cytotoxic T cell activity will be able to kill the cancer cells better, and those with a low cytotoxic T cell activity may not be able to kill the cancer cells so well. And only the step 7 seems to play a significant role in the whole immune evasion landscape that we observe. Although theoretically speaking, as I just now explained to you, step 1, 2, like antigen release, antigen presentation, T cell trafficking, T cell infiltration, these are the steps that we identify from the immune cancer cycle. But it seems like from pancreatic cancer point of view, particularly in the Australian dataset and the TCGA dataset, we only able to find that the step 7, which is the step where the cytotoxic T cell can or cannot kill the cancer cell, is the most crucial step that actually play a role in determining the patient's overall survival or their disease progress-free survival. So this gives us a hint that we may need to look a little bit closer on cytotoxic T cell activities as an important key to understand what is going on between the pancreatic cancers and our immune cell. So once we understand because of the high cytotoxic T cell is an important role, we actually did a little bit deeper and we noticed that genital age of diagnosis is not an important factor from this Australian dataset and TCGA. So regardless whether when they was diagnosed, despite from the epidemiology data, we saw that patients at the younger age will have better prognosis and patients at the older age will have poorer prognosis. But from the Australian dataset and the TCGA dataset, both show us that the age of diagnosis have not important role. Perhaps this is just limitations in the datasets, because as you understand, the numbers are just only 60-somethings of the patients. We may not be able to capture this whole scenario very well, but from the dataset, we don't see a clear association between the age of diagnosis and the gender with the cytotoxic T cell activity. So because of that, the next step is we will focus developing a model focusing on cytotoxic T cell only, but without looking into much on the age and the gender. So what we do is we take out all the gene signatures of low cytotoxic T cell. When the cells are having low cytotoxic T cell activity, what do they mean? So we take out all the gene signatures from the Australian dataset and the TCGA dataset, and we do a mapping, and we noticed that there was 15 genes that both up regulations in both of the dataset, and there were 52 genes that are actually down regulated in the datasets that happen in both of them. So I will focus on those that is common gene that is happen in the Australian dataset and TCGA datasets, just to avoid that there is any potential dataset bias or ethnicity related biasness. And when we do all these genes together, we put them together, we use our bioinformatic analysis method to group this kind of protein together. And we realized that it seems like interleukin 6R is one of the important signaling pathway. But to our surprise, we start to notice that HDAC is also playing a role. So histone deacetylations seems to have a role in this low cytotoxic T cell. So it started to give us a hint that maybe epigenetics and alterations is also playing an important role. So from that observation, what we did was we put in all our low cytotoxic T cell activity markers, and we put it into this connectivity map analysis. Connectivity map analysis is a software that's developed by our Broad Institute. So we have a good collaboration with them, and we are able to use that data set to actually predict the drug activity based on the low cytotoxic T cell gene signature. So when I put this low cytotoxic T cell gene signature into the data set, and the database will run the analysis, and it will tell me that what are the signatures of these expressions compared to the drugs that is already available in the market. This is a good approach because those gene signatures that is already been tested and by the different drug compounds in the market, it will help us to reposition or repurpose the drugs that is already available in the market. So in terms of toxicities, I don't have to worry too much because if I can find that these compounds that have already been approved in the market, they could be easily repositioned for me to use it for my patient in the future. So to our surprise, we noticed that HDAC inhibitor, it seems to be constantly pop up in the list. So in the low cytotoxic T cell activity signatures, we already see HDAC is a common pathway, seems to be affected. And connectivity map give me another assurance that HDAC inhibitors seems to be playing a role in supporting our cytotoxic T cell activity. So because of that, that opened up a channels for us to understand that maybe HDAC inhibitions may be one of the reasons they can help us to address immune evasions in pancreatic cancer. So what we did is, because we understand cytotoxic T cell is the key role in immune evasions for pancreatic cancer, in my lab, we developed the cytotoxic T cell resistant pancreatic cancer cell. So how we do it is we take our pancreatic cancer cells from the ATCC. So the cell line that I use is SW1990. In fact, actually, we developed at least 4 to 5 pancreatic cancer line that is actually cytotoxic T cell resistant. So we take the cells and we challenge them with cytotoxic T cell. So some of the cells, cancer cells, will die off in the first round of the cytotoxic T cell challenge. Left with maybe 10 to 20% of the cells will survive. So these 10-20% cells will allow to repopulate in the lab. And after a while, when they fully grow back, I will challenge them again with a cytotoxic T cell on the second round. Then in the second round, some of the cells will still die off and left with maybe about 30-40% of the cell will survive. So I constantly repeat this process for a few rounds until all the cytotoxic T cells are no longer able to eradicate my pancreatic cell. So I establish a new line. What we call them is cytotoxic T cell resistance cancer cell. So I have the parental cell, which is without any treatments of cytotoxic T cell. And I have another cell line, which is constantly challenged with cytotoxic T cell. So when I have both of the cell line, what I did was I also go through a high throughput phenotypic screening using 133 bioactive molecule. So these 133 bioactive molecules are all the FDA approved compound with potential anti-cancer activities. So we carefully selected these 133 compounds and we screen them on both of the pancreatic cancer cells that have not been challenged with cytotoxic T cell. And we also screen the cells that is carrying resistance to cytotoxic T cell. So the chart that you're seeing here is at the end of the day, 133 of these compounds that eventually found out to be useful are the ones who will be able to actually do both of the killing of the pancreatic cells and the cytotoxic T cell. So this is how we develop the cytotoxic T cell resistance line. So eventually you will see that this is actually the first challenge. So when we first challenge, you will see some of the cells are responding to the cancer cells. That's why they are dying. But eventually at the end of the day, the one that is resistant to pancreatic cancer cells are resist to the cytotoxic T cell. So that's how we establish our cytotoxic T cells model. And this model, because during the screenings, we realized that HDAC could be playing an important role in terms of blocking the activities. And that's why we selected a long range of HDAC inhibitor. Each and every one of them will have different activities. Some of them are very selective to a certain type of HDAC. We realized that certain of the HDAC inhibitor have very good activity. So because when I put in the HDAC inhibitor, it seems like I can reverse the resistance cells back to sensitizing to cytotoxic T cell. So this is one of the very interesting phenomena that we observe. And we noticed that it is not all the HDAC inhibitor can do that. Only very selected HDAC inhibitor can do that. So if you look at the particular chart, you will realize that on the left-hand side is all the sensitive cells that is already sensitized to cytotoxic T cell. And when I add the HDAC inhibitors, all of them definitely will respond. But when in the cytotoxic T cell, we actually notice that when I give them, the sensitivity seems to be pushing even further to the left, which means that they are actually getting reversed in terms of the cytotoxic T cell activity back to its original. So one of it you can actually see is the desinostat, which is actually on the far left of this dose response curve, which means that now with the treatment, the resistance cells seems to be more responding to the HDAC inhibition treatment. So we're able to find reasons why the HDAC inhibitor may be a good solution for pancreatic cancer patients who are resistant to immune cells. And the HDAC inhibitor, especially desinostat, may be having a role to push them to be more resistant or more sensitive to the cytotoxic T cell. So what we did was we also want to understand why certain of the pancreatic cancers is responding to certain type of the HDAC inhibitor. but some of them are not actually. So what we did was we take out their structures of each and every one of the HDAC and we run a switch target predictions. This is a 2D, very rough SAR predictions activities. And we noticed that givinostat is particularly interesting. They only target a certain type of the receptors, despite all of them target HDAC. So the blue color that you're seeing are the HDAC markers. So obviously all HDAC inhibitor will target all the HDAC marker. But what is interesting is on the far right-hand side, you notice that each and every one of the HDAC does not bind to the same target. So that's probably give us another clue that givinostat and desinostat may be the reasons why these two compounds can actually target a selected range of the compound on the markers that help to reverse the cytotoxic T cell activity. And the HDAC that is less useful in this case, which means that like when I use trichostatin A, it doesn't seem to be help me to reverse the CTL resistance. And it seems like trichostatin A only have a very narrow range of the compound that can target. That explains why not all the HDAC inhibitor will work in terms of reversing cytotoxic T cell resistance. And we need to look at a very particular range of the HDAC. So when I take out all this, we know givinostat and desinostat are the ones who respond very well in the CTL resistance reversing effect. Vorinostat and trichostatins are the one that is not so much useful in terms of reversing a cytotoxic T cell activity. So if I pull out the common pathway, the two set of the HDAC inhibitor, I notice that HDAC is always the one that they target. So they are the common pathway. So we put them aside. And I noticed that givinostat and desinostat only target the NOS1 pathway and the HDR pathway. And these three markers is not being targeted by vorinostat and trichostatin. And vorinostat and trichostatin pathway, they will target all the one that is actually red in color. So that gives us another clue that givinostat and desinostat may be targeting NOS1 and HDR as the way to reverse the CTL resistance in pancreatic cancer. Not so much on those that is highlighted in the red color. So in the future, what our group is now working on is to look at a little bit deeper how the NOS and the HTRs are responsible for the cytotoxic T cell immune resistance pathway. So this is actually just a summaries on what we actually done. So we started from the pancreatic cancer data set, which is the Australian data sets and the TCGA. And that helped us to separate into two common scenarios where high cytotoxic T cell patients will have better clinical response. And those who have the very low cytotoxic T cells are the ones give a very bad prognosis. Based on that, we use our bioinformatic tools to understand the gene signatures and the protein-protein network. And at the same time in the lab, I developed the pancreatic cancer cells that is responding to cytotoxic T cell, and also the pancreatic cancer cells that is resistant to cytotoxic T cell. So despite the challenge of cytotoxic T cell, the pancreatic cancer will still survive. And when I do a high throughput compound screening, so we identify that HDAC inhibitors could be the one that is responsible for reversing of cytotoxic T cell activity. This observation is also the same observation that we've seen from our population's bioinformatics analysis. And that's why our group focused on HDAC as a way to prove our concept. And we obviously repeated the experiment by adding the HDAC inhibitor with the cytotoxic T cell. And obviously, with the right HDAC inhibitor, the pancreatic cancer cells now responds to the cytotoxic T cell. And that's why the pancreatic cancer cell can be eradicated using the cytotoxic T cell. So we conclude that HDAC or epigenetics could have an important role, and HDAC inhibitors such as givinostat and desinostat could be the ones which are useful for as an adjunct therapies for patients, maybe for the pancreatic cancer patient, especially for those of them with a very late prognosis. So this will be my concluding slide. Alone, we can do only this much. Together, we can do so much better. So that's why I'm actually also interested if in this call, if there's any one of you who are interested to also join forces with us. Our group, as you can see, we have developed the pancreatic cancer cells that are resistant to cytotoxic T cells. We are very much interested to understand how we can actually eradicate these cells better. And we're also interested to understand why cytotoxic T cells, resistant pancreatic cancer cells are so much difficult to be killed. We understand part of it from our analysis, but our group may overlook certain of these important parameters. That's why we're open for also collaborations. Any one of you who have interesting idea, we could also collaborate. And at the same time, if you are a synthetic chemist or biological natural product chemist, or any one of you who have a new compound that you synthesize, and you may want to be testing on the pancreatic cancer, especially on the model that we developed, the pancreatic cancer and immune resistance pancreatic cancer cells, our group also welcome you to send compound to us, and we can test it for you, and we can get back the result for you. And you may actually suddenly have answers for killing the pancreatic cancer cells sitting inside your lab. So we are definitely interested to open this discussion. In fact, I have a very good collaborator from India as well. He constantly synthesizes a lot of compound, and he sent to me for testing. And after the testing, I'll send the result back to him. And obviously, these compounds are not belong to me. I won't claim the copyrights or whatever rights for me. So my collaborators will take these results and they will publish, and we are just a collaborator to them. So for my interest is we want to know, is there a possible answers as a treatment? And at the same time, I will advise them maybe they can start to modify certain structures, because based on the first testing result, I can advise them which compound would be probably useful and interesting for them to continue further of their synthesis or their structural modification. So that's how we work together very well as a team. So with that, I will open for any questions and answers. I will now stop my sharing.
Thank you so much, Dr. Mai, for delivering such a wonderful session on targeting immune evasion in pancreatic cancer. You started the session introducing the basics of cancer and showed the survival statistics of patients suffering from pancreatic cancer in comparison to breast cancer and cervical cancer. You also described the factors that may affect the cancer immunity cycles in PDAC. You discussed about the association of immune activity scores of pancreatic cancer patients with overall survival. And you also discussed about the latest topic on pancreatic cancer. It was a nice session, sir. And now there are some questions from the participants. I'll be asking you one by one. So the first one is, sir, can targeting immune checkpoints such as PD-L1, PD-1 axis improve outcomes in pancreatic cancer patients?
Obviously, yes, because in the just now the cancer immune cycles, one of the cancer killing steps is actually powered by the PD-L1s and PD-1. But these actual scenarios where we see patients who given PD-L1 or PD-1 inhibitors, they don't seem to respond that much. So that's why immunotherapies are still, theoretically speaking, they should work, but we don't see much improvement in terms of clinical outcome. So we still need to understand why. If you ask me, will they have a role? Yes, they have. But in terms of clinical outcome, we don't see that much of the improvement that we expected.
Okay, sir. Right, sir. Right, sir. Thank you. The next one is, sir, what are the challenges and opportunities in utilizing immunotherapy for pancreatic cancer treatment?
So as I mentioned, the outcomes, the clinical outcomes that we expected them to jump, just like in lung cancers and stuff like that, we see a very good response in pancreatic cancer, in lung cancer patients. But pancreatic cancer, we don't see that much of the jump. And as I mentioned just now in the immune cycles, the PD-L1 and PD-1s and all these immunotherapies are only addressing one particular part, which is the cancer killing part. So that part seems to be an important part based on our bioinformatic analysis from TCGA dataset and the Australian dataset. But again, we'll have to caution the limited available data in the bioinformatics analysis is because we don't have a very good quality of samples to go a little bit deeper. So I believe we are still missing the link, how the immunotherapy patients can benefit truly for pancreatic cancer patients.
You're right, sir. Right, sir. Thank you. The next question is, sir, how are there specific biomarkers that can predict responses to immune-based therapies in pancreatic cancer?
That is also another very important questions that we're trying to answer. At these particular junctions, I will tell you there is no very good biomarkers for pancreatic cancer. The so-called the CA9 and CA19s, at one point, we were using it as a pancreatic cancer biomarkers, but we all know they are not specific to pancreatic cancer. And it is also has a high positive errors because it is also related to other markers in our body. And at this particular junction, we don't have it. But you see, based on our bioinformatics analysis, it seems like the gene signatures related to cytotoxic T cell activity may be the answers to whether the cancer patients will respond better or not. So that is based on our findings from the TCGA and the PACA-AU, which is the Australian dataset. So bear in mind that these two particular dataset is very Western driven. We don't have a very Asian-related answers. So even in Malaysia, I would not bet on this to be used completely in our Malaysia setting. It's because we still need more data to actually do this. So let's say if any of the people in this call will have access to a large data set of pancreatic cancer, particularly in our Asia regions, we will be more than happy to actually work together with you to actually dig down into the comparison, because we have actually done the analysis for the Australian dataset and the TCGA. So for us to actually analyze another dataset is actually quite easy. We just need to work together with the respective team that have the access to those datasets. Unfortunately, in Malaysia, we don't have it. That's why I'm calling people from the call and say, anyone who have this, please come forward. We are happy to work together with you.
Definitely, sir. Thank you so much, sir. So the next question is, can combination therapies involving immunotherapy and traditional chemotherapy, radiation therapy, can improve the outcomes in pancreatic cancer patients?
This is what I think the current clinical settings are trying to do, because we are kind of desperate for pancreatic cancer patients. As I mentioned to you, most of them will not survive in 1 year. Even the 5 years prognosis was like saying 1% or 2%. Generally speaking, we only seeing patients only survive for a few months. So because of that, many patients will try to fight. That's why they will combine immunotherapy, chemotherapy, and also targeted therapies based on person's financial status and also the support that they can get. So currently, yes, they are using it as a combination therapy. But from our analysis, we noticed that the combination doesn't seem to be exactly working well. In fact, actually, my lab have actually tested the chemotherapies and immunotherapy together, and we don't see a very good outcome. That's why we think that there is a missing link that we are trying to understand. So based on what we found today, it seems like we can also combine with other drugs. Let's say epigenetic drug like HDAC. HDAC is an epigenetic drug. It could actually open another new horizons for us to look at. So the combination therapy is definitely one of the strategies that we should investigate more. The question will be which combination. Yeah. So that's why we need more of the data to support.
Right, sir. Thank you, sir. So next question is, what are the potential side effects and toxicity associated with immunotherapy in pancreatic cancer, and how can they be managed?
Well, most of the immunotherapies, well, we still see there's a lot of immune suppressions issues, and there is also some toxicities of the particular organs that we need to be cautious about. That's why your clinical teams, like for example, your clinicians and your pharmacists, are the one who actually help to manage all the toxicities. And although nowadays we have a lot of targeted delivery systems that can actually reduce in terms of the toxicity, but we still have a lot of like nausea, vomitings, and immune suppressions issues that we need to address.
Right, sir. So one last question, sir. Are there any promising preclinical and clinical studies targeting novel immune evasion pathways in pancreatic cancer?
This is a very challenging question. Yeah, obviously, they have a few big studies in the market recently. Also in the research fields, I've been seeing some groups have been trying to propose. But if you ask me, so I think that there are still need more studies to support the outcome. So everyone's are still trying to rush to the finishing line, as per se. But I think we still need more information for those.
Right, sir. Thank you so much for answering all the questions wonderfully, sir. And so here we come to the conclusion of this webinar. So in concluding our 47th SPSR International Webinar on targeting immune evasion in pancreatic cancer, I am profoundly grateful for the collective expertise and dedication demonstrated by our speaker and participants. Throughout this enlightening session, we have delved into the intricate mechanism of pancreatic cancer and explored innovation strategies to overcome immune evasion, paving the way for the more effective treatments and improved patient outcomes. The depth of insight shared today underscores the critical importance of interdisciplinary collaboration in advancing cancer research and therapeutic inventions. By harnessing our collective knowledge and expertise, we continue to drive progress in the fight against this challenging disease. On behalf of SPSR, I extend my heartfelt thanks to our distinguished speaker, engaged participants, and dedicated organizers for their invaluable contributions to this webinar. Your commitment to excellence and innovation is truly commendable and serves as a beacon of hope for patients and families affected by pancreatic cancer. We extend our sincere gratitude to Dr. Shashi Alok, the National President of SPSR, for gracing us with his esteemed presence today. In acknowledging your dedication and leadership, we express our heartfelt thanks for your invaluable contributions. In extending our deepest gratitude, we express our sincere appreciation to the esteemed speaker, Dr. Chun-Wai Mai, whose generosity in sharing his profound expertise and invaluable perspectives has enriched our understanding of targeting immune evasion in pancreatic cancer. A special acknowledgement is extended to our convener, Mrs. Monika Sabharwal, whose pivotal role in orchestrating this insightful event has been instrumental. We extend heartfelt thanks to all the participants, recognizing the collective efforts that have effectively pushed the boundaries of knowledge and fostered a spirit of collaborative learning. Together, your contributions have made this webinar a resounding success, and we look forward to continued collaboration in advancing pharmaceutical sciences and research. Thank you for being an integral part of the 47th SPSR International Webinar. Your active participation and contributions have been invaluable, and we look forward to future endeavors that contribute to the continuous betterment of healthcare and well-being for all. Thank you once again for your participation and unwavering commitment to advancing the frontier of science and medicine. As we conclude this webinar, let us carry forward the momentum gained today and redouble our efforts to make meaningful strides in cancer research and patient care. Together, we work towards a future where immune evasion is no longer a barrier to successful treatment outcomes in pancreatic cancer. Have a wonderful day. Thank you so much, sir. So we may leave the session, sir. Thank you so much, sir.